just wanted to talk a little bit about some of the nuances with sdh-deficient gastrointestinal stromal tumors specifically, since I think that's the most pertinent for the audience. But when we are looking at sdh-deficient GIST, they essentially exclusively arise from the stomach, and we seem to see that more in the body and the distal stomach as opposed to the proximal stomach. However, it's still an open question from the surgical side of things whether there's any, or what is the benefit of, instead of just doing a partial gastrectomy, is a distal gastrectomy or a subtotal gastrectomy relatively risk reducing? We don't know that. And we've talked about a trial to, trying to answer that question, which for numerous reasons would be very difficult to carry out with adequate power to be able to definitively say one way or the other. That being said, when we're talking about the SDHC epigenetic silencing subtype of GIST, that is very frequently multifocal, and some of those tumors, I think, often end up being more proximal than in other SDH varieties. When we encounter lymph nodes that are suspicious or likely involved, it's much more common to happen in SDH deficiency, I think, depending on who you talk to or what series you're looking at. I usually see about 15 to 20%. Dr. Sicklick may quote a higher number than that. They do tend to show up on imaging pretty reliably, but then also as part of any operation, we're taking a good look around and a feel as well in order to try and identify and remove these lymph nodes at the same time. But there's no clear benefit for doing an extensive lymphadenectomy or removal of apparently normal lymph nodes above and beyond what appears to be involved with disease. With the liver, we have a lot of adjuncts available. And we have some organ-specific regional therapies as well. But some of the adjuncts that we use in surgery include ablation and then also partial hepatectomies. I know we also talk about liver-directed therapy, which may be bland embolization, Y90 treatments, and there's also different types of ablations between cryoablation, microwave ablation, histotripsy. So a lot of different approaches out there. One thing that we don't have a lot of are head-to-head comparisons in order to really say definitively is one type of ablation better than the other, specifically with just histologies. With the peritoneum, right now really, a complete cytoreduction is the optimal strategy. So one of the benefits that we have with GISTs in general is that it has this pseudocapsule around it. It tends to push structures as opposed to invade. And so a lot of times we can do peritonectomies to strip the surface of the abdominal cavity without having to go into removing multiple segments of small intestine or colon. And so that is one thing that is relatively favorable, and that does help facilitate complete debulking. So a lot of, like that picture that Dr. Sicklick had in his presentation, a lot of those larger tumors that you see upon opening the abdominal cavity are going to be removed through an omentectomy or removing the omentum, which is the curtain of fat in front of our intestines, and stripping those areas of peritoneum. And when we have the situation where SDH-deficient GIST has spread beyond the abdominal cavity, such as to bone, then there are other adjuncts to deal with that, as far as perhaps resection or ablation, or just careful monitoring of those areas over time. Some of the goals of surgery, as with non-SDH-deficient GIST, really a lot of the benefit comes from relieving active symptoms, whether it's pain or obstruction or bleeding. And I think there is benefit also to resetting the clock on the disease burden. And as Dr. Sicklick said, that threshold of 2 centimeters is a reasonable consideration as well, as far as, is there a benefit to removing that? But one of the things we also want to make sure of is that we preserve a patient's eligibility for clinical trials in the future. So one of the worst things that I could do for somebody is a really aggressive liver operation, which then fundamentally alters your liver function tests moving forward. And then some of the folks from the panel before would say you're not eligible for a clinical trial because your AST or ALT or bilirubin are too high. So it's a balance of those sorts of things. And these Kaplan-Meier curves here are from the NIH wild type and SDH-deficient GIST experience, looking at event-free survival after surgery. I think that fundamentally what we say is that our goal with surgery is to try and control disease, and having recurrence is not necessarily unexpected, but we want to try and prevent or prolong that for as long as possible. But one point that I think really bears mentioning is that resectability is truly in the eye of the beholder. I may say one thing, Dr. Sicklick may say another thing, and 5 other surgical oncologists may say something else. I think the value of multiple opinions is really important, but you know, I think that it's both objective and subjective in its nature. And I think that resectability also goes back to, as Dr. Sicklick was mentioning, the patient and the disease. There are technical considerations, and there's also patients' other medical problems to take into account when judging resectability. Some of the things that we more commonly employ, particularly in sdh-deficient GIST, but just in general, is diagnostic laparoscopy. We use that for folks who have peritoneal involvement, because I think it gives us much more information than imaging may be able to provide. The aspect of combining liver resection and ablation at the same time in order to try and achieve optimal debulking of the liver at the time of surgery. And then in very, very highly selected patients, there might be an indication for something like veno-venous bypass. So I'll talk a little bit more about each of those. So laparoscopy, this is where, you know, some of these nodules that we can see here up on the diaphragm peritoneum in the top picture, on the omentum in the middle picture, and down on the pelvic peritoneum on the bottom picture, would not reliably show up on imaging, whether it's CT, MRI, or PET scan. And the visual information we get from a laparoscopy, I think, is invaluable because it gives you a real sense of overall disease burden. It is also an opportunity to get tissue harvest for analysis, whether you need to repeat next generation sequencing of that tumor and see what mutations have occurred since the last time that was performed, or if you're looking at an assessment of treatment response over time. And laparoscopy is an outpatient procedure that can be repeated, and I would say not zero morbidity necessarily, but quite low. And then with liver resection and ablation, we tend to opt to remove tumors that are going to be 3 centimeters or larger, and particularly on the periphery of the liver. I think the ablation is a really ideal approach in order to deal with deeper and smaller tumors within the liver tissue itself. And again, as what we try to do with this is remove or ablate as much tumor tissue as possible while preserving as much normal liver tissue as possible. And the last one with the veno-venous bypass, I won't go too much into this, but basically it's a way for us to get isolation of the vena cava, because sometimes we do have metastases that are growing very close to it, and getting control of that vena cava blood flow behind the liver allows us to remove those metastases. And if needed, we have not done this for patients with GIST, but if needed, it can facilitate resection and reconstruction even of a segment of the vena cava. But again, this is quite unusual to really have a solid indication to do. There are limitations of surgery. I mean, as a surgeon, it's hard for me to admit that, but it's true. We cannot remove what we cannot see. And of course, we know that there's going to be microscopic foci of GIST that we don't have a way to detect and preemptively remove at the time of surgery. There are short interval recurrences that are known to happen, and that goes back to the biology aspect that Dr. Sicklick was mentioning. In sdh-deficient GIST, we will often see early recurrence within the liver after liver surgery for sdh-deficient GISTs. That's not to say that the benefit of that surgery is totally negated, but because what we also will see is that some of those new metastases will grow and then stabilize and stay stable for a long period of time. And there's still been a fundamental reduction in the total disease burden in the liver. And the other is that we can do a lot with cytoreductions or debulking surgeries, but probably for a single patient, there's only so many that we can really effectively do, just based off of scar tissue, based off of cumulative organs that are resected over time. And then, of course, none of us are getting younger. And so as we get older, then our ability to tolerate surgeries also relatively diminishes. With future directions, we really need to improve systemic treatment options. And thanks to some of the people in the room here, including Dr. Sicklick, trying to open and expand those options is really critically important because, again, getting better systemic control will then increase patients' candidacy for these surgeries, both through disease reduction or even stability over time, and that is a big impact on our counseling. And then, one area of interest, especially for me, is improving regional treatment options. Because as a surgeon, what we do with cutting things out is fundamentally a local treatment. And as I said, we cannot remove what we cannot see, but there are probably microscopic foci. If there are ways for us to enhance what we do by removing the macroscopic disease, whether with drug treatments either directly into the liver or perfusions of the abdominal cavity, can we then also treat the microscopic disease through that regional treatment approach? That's an active area of interest and research. We have some options with the liver at this point, but we really, I think the peritoneal side of it is wide open for improvement. So with that, you know, surgery is still fundamentally a critical aspect of care for patients with sdh-deficient GIST. I do believe that everyone should have at least 2 opinions from surgical oncologists who frequently treat patients with GIST as far as the question of resectability. And I know that's not always possible, but it is an ideal. And really, ultimately, the value of surgery, we can judge on some extent as far as, did the patient experience a complication? What does the scan look like after surgery compared to before surgery? But fundamentally, you and your caregivers are the best judges of the value of that surgery that was done. And that's part of the discussion of, is this a worthwhile endeavor for you to pursue or not? So with that, I think we do have a few minutes for questions. Thank you all.